For attending. Without further ado, I'd like to introduce our first speaker, who is Dr. Jessica Krahn. Jess is a hematology resident at UBC, having completed her internal medicine training at the University of Alberta. She'll be speaking to us this morning. So, Jessica, thank you very much.
All right, good morning, everyone. As you heard, my name is Jessica, or Jess. I'm one of the hematology R4s currently at UBC. I have to say I'm a little intimidated because there's so many scientists in this room. As I went through the program, I was like, oh my gosh, these people are legit. And as you can see here, my background is entirely clinical. I have a nursing degree and then I've gone into medicine, but I am absolutely not a basic scientist. So my focus today is we're going to be talking just really an introduction to beta thalassemia and advancing therapies, including gene therapy. Whoops. But I want this to be a general overview and really from a clinician's perspective, because the real highlight is after this we get to hear from a patient who's had gene therapy. And so I just want this to be a bit of an introduction for her presentation, which honestly I think will be far more interesting than mine. All right. I have no disclosures, and let's get into it. So just to introduce our topic, thalassemia is a group of hemoglobin production disorders. We're going to focus on beta thalassemia today, and specifically its most severe form, which is transfusion-dependent beta thalassemia. The objectives that I have for our talk is to just briefly cover the epidemiology of transfusion-dependent beta thal, the pathophysiology, the clinical manifestations, and then our current treatment for beta thalassemia, including emerging transformative therapies such as gene therapy. And then we'll be hearing from Emily, so the patient. So thalassemia is the most common monogenic disorder worldwide. Approximately 1.5% of the global population carries a beta thalassemia allele, and there are greater than 300 mutations described. In 2021, there were approximately 1.3 cases of transfusion and non-transfusion dependent beta thalassemia globally, and around 40,000 affected infants are born each year, half of whom are transfusion dependent, so have the most severe form. More than 90% of patients live across tropical regions, from sub-Saharan Africa through the Mediterranean and the Middle East, the Indian subcontinent, as well as Southeast Asia. And this reflects a historical survival advantage against malaria. Canadian epidemiologic data is pretty limited. We don't have a central registry, but we do know that we have increasing cases with immigration trends. So what is thalassemia? So to understand it, we need to review just normal hemoglobin physiology. So hemoglobin is a tetramer that is comprised of 4 globin chains. The main form of adult hemoglobin is hemoglobin A, which is composed of 2 alpha chains and 2 beta or beta-like chains. Each globin chain is bound to a heme group, which contains iron, which allows it to reversibly bind oxygen, and hemoglobin, therefore, is our main way of transporting oxygen throughout the body. Alpha globin genes are located on chromosome 16, and the beta globin genes are on chromosome 11. So the pathophysiology, so fundamentally thalassemia is a disorder of globin chain imbalance. So beta thalassemia, it's an autosomal recessive disorder that's caused by mutations in genes encoding for the beta globin chains. And so this leads to either reduced in beta plus thalassemia or absent in beta 0 thalassemia production of beta globin. And normally we have alpha and beta chains that exist roughly in equal amounts. But in beta thalassemia, because of the reduced or absent beta chains, we have an excess of unpaired alpha chains. Sorry, it's going forward automatically. There we go. Okay. So the unpaired alpha chains then cannot form functional hemoglobin. They have all these extra chains floating around. And so instead they aggregate into unstable tetramers composed of only alpha globin. These are called alpha-4 tetramers, which are dysfunctional and they're toxic. These tetramers precipitate within red blood cells and form inclusion bodies called hemichromes, and these generate reactive oxygen species, which release free iron, leading to oxidative damage of the cell membrane and the internal structures. So to go into this a little bit more detail, let's talk about ineffective erythropoiesis. So a significant amount of the oxidative stress that happens in beta thalassemia happens even before the red blood cells leave the bone marrow, so happens in our red blood cell precursors. And so in severe untreated beta thalassemia, the bone marrow may increase the red blood cell production up to 10-fold, but more than 95% of the cells die before entering circulation, so die in the bone marrow. And this is referred to as ineffective erythropoiesis. The body responds to this chronic anemia by increasing our erythropoietin, which actually drives ineffective erythropoiesis even more by just ramping up our red blood cell production. And this results in massive bone marrow expansion, leading to skeletal deformities, extramedullary hematopoiesis, and causing enlargement of the liver and the spleen. Then the red blood cells that are able to enter into the circulation are abnormal and they're fragile, and so they're destroyed prematurely in the spleen, which is extravascular hemolysis, or in the bloodstream, known as intravascular hemolysis. And this ongoing destruction further contributes to anemia and releases free iron. So in addition to the anemia, complications of chronic hemolysis include elevated bilirubins, which can result in gallstone disease, as well as increased risk of thrombosis, including deep vein thrombosis, pulmonary embolism, stroke, and myocardial infarction, as well as pulmonary hypertension. And now iron. So despite chronic anemia, patients with thalassemia develop iron overload. Ineffective erythropoiesis suppresses hepcidin, which leads to increased intestinal iron absorption and release of stored iron. In addition, patients receiving regular transfusions for transfusion-dependent thalassemia accumulate iron from the transfused blood. Each unit of blood actually contains between approximately 250 milligrams of iron, and so patients can accumulate up to 12 grams of iron per year if they're on a chronic transfusion protocol. Humans have evolved to try and conserve iron as best as we can, and we have no natural mechanism to excrete excess iron. And so this excessive intake leads to overload of iron in the body. And it especially accumulates in the liver, the heart, the endocrine glands, and this can lead in the liver to cirrhosis and increased risk of hepatocellular carcinoma. In the heart, this can lead to arrhythmias and heart failure. And in the endocrine glands, this can lead to things like growth deficiency, as well as hypopituitarism, diabetes, thyroid disease. So with all of that, despite thalassemia being a blood disorder, the manifestations really are head to toe and essentially can affect any organ system. And so overall, we have seen life expectancy improvements in patients with severe beta thalassemia in recent decades. Without transfusions, patients with thalassemia major would typically die before the age of 10 to 15. In the 1970s, median survival was only 17 years, but more recently, we've seen overall survival of more than 50% of patients and up to 80% of patients at 50 years of age. This is largely because of improvements in treatment with iron chelation to prevent the effects of iron overload. But still, the average lifespan remains lower than the general population, and patient quality of life still suffers quite significantly. So how do we treat thalassemia? So to now, the cornerstone of treatment for transfusion-dependent thalassemia has been transfusions. The goals are to correct severe anemia, to prevent complications, to suppress that ineffective erythropoiesis. And transfusions are typically given every 3 to 4 weeks with a pre-transfusion hemoglobin target of approximately 95 to 105, depending on the patient. But transfusions are associated with significant complications. Alloimmunization can occur in about 37% of patients. And iron overload, as I mentioned, is inevitable. And requires lifelong iron chelation, which comes with its own set of side effects and disease morbidity. Additionally, chronic transfusion therapy is just a huge time burden for patients and can be really burdensome for patients trying to just live on with their life. So given the significant morbidity associated with transfusions, iron overload, time, there has been a major focus more recently on trying to have therapies that improve hemoglobin, improve the anemia without needing transfusions. Before I get into gene editing, I just want to briefly talk about one of these newer therapies, which is a medication that was recently approved for thalassemia. This is called luspatercept. Luspatercept is an injectable medication. It's given every 3 weeks, and it works as a ligand trap, which helps to address the issue of ineffective erythropoiesis. Oops. Essentially, it traps specific pathogenic growth factors which interfere with red blood cell maturation, and by blocking these growth factors, it allows the red blood cells to mature properly and raises the hemoglobin. So a recent trial called the BELIEVE trial, a phase 3 trial of luspatercept in transfusion-dependent beta thalassemia, which was published recently, found that 21% of patients on luspatercept reduced their transfusion needs by at least a third in weeks 13 to 24 of the study, and 71% of patients achieved a reduction of at least one-third of red blood cell needs over the total time period of the study. But importantly, the majority of patients still required transfusions. So this just reduced their transfusion needs, but it did not stop the need for transfusions altogether. So now we'll move on to therapies which allow patients to be transfusion-free, curative or transformative approaches. These approaches include hematopoietic stem cell transplantation and gene therapy, including both gene addition and gene editing strategies. So first, just briefly on stem cell transplantation. So this remains the only curative therapy, curative meaning genetic cure, fixing the genetic defect that causes beta thalassemia. And this is where we have a healthy donor who does not carry the beta thalassemia mutation. They donate their healthy hematopoietic stem cells for transplantation. Now, for best results, transplants should be from HLA-matched sibling donors. And of course, this significantly limits the donor pool. And it is most effective in young patients, ideally under the age of 12. Outcomes in adults are far less favorable due to higher rates of graft versus host disease, graft failure, and mortality, and so it's generally not recommended for patients older than 18 years outside of clinical trials. So gene therapy has been a major advancement over the past decade, and while it does not eliminate the underlying mutation, it can provide a functional cure for patients with transfusion-dependent beta thalassemia. So let's start by talking about gene addition strategies. So beta-cel, or Zynteglo, is a lentiviral gene addition strategy that works by adding a functional copy of a modified beta-globin gene into the patient's hematopoietic stem cells. So this involves collecting CD34 positive stem cells from the peripheral blood via apheresis. Essentially, it looks kind of similar to a dialysis machine where we take the blood, we spin it, and we take out the stem cells that we want. And then those are sent away to a lab where a functional beta-globin gene is introduced using a replication defective, self-inactivating BB305 lentiviral vector in the lab. Lentiviruses are RNA viruses that integrate into the host genome. The viral RNA is reverse transcribed into DNA and then inserted into the patient's chromosomal DNA, allowing for permanent gene expression. So the vector carries this modified beta-globin gene. This is a modified beta-globin that contains a single amino acid substitution. And the beta-globin regulatory elements as well are put all into this viral vector, which is then transduced and then produces this functional beta-globin protein. And then once you have the functional beta-globin, this can then combine with the alpha chains to create functional hemoglobin. So how has this panned out for us? So we have phase 3 trials that have shown really actually quite impressive results. So we have the results from North Star 2, which was published in 2022. This was an open label phase 3 study of the efficacy and safety of beta cell in adult and pediatric populations with beta plus transfusion dependent thalassemia, so mutations where they still make some beta chains. And this did demonstrate transfusion independence, which was defined as a hemoglobin greater than 90 without hemoglobin red blood cell transfusions for 12 or more months. And this was achieved in 91% of patients, so 20 out of 22 patients. North Star 3 was a separate trial which included patients with only the most severe type of transfusion-dependent beta thalassemia, so beta 0, where they make none of their own beta chains. And in this group, they achieved transfusion independent in 89% of patients, so 16 out of 18 patients, so really quite impressive. The side effect profile was mainly related to myeloablative busulfan chemotherapy, which included low blood counts, infections, bleeding, and some liver toxicities. This is very similar to what we see in any kind of an autologous stem cell transplant. And long-term follow-up has shown durability of response for up to 10 years with no reported cases of insertional oncogenesis. So Gene editing, on the other hand, represents a different but equally transformative approach. So here, instead of adding a new gene like we do in beta-cell, the strategy used by exa-cel or Casgevy changes how the existing genes are turned on or turned off. So to understand how this works, we need to look at a protein called BCL11A. So in utero, I'm just trying to, am I able to get the cursor on this screen by any chance? It's showing up there. Okay, I'm trying to find it on this screen here. Are you able to help me? Sorry. I'm trying to get it so that I can see below this. It's cut off. But I don't know.
I apologize.
No, that's okay. You know what?
Laser pointer might be.
No. That's totally fine. Give me one moment. I can even pull some stuff up on here. Totally fine. So let's pull this up here. Okay. So for this one, we need to understand BCL11A. So in utero and shortly after birth, our main hemoglobin is fetal hemoglobin. And this is made of 2 alpha globin chains and 2 gamma globin chains. But shortly after birth, BCL11A is a transcription factor which binds to the promoter of fetal hemoglobin, and it starts to suppress it. And this leads to decreased fetal hemoglobin production and hemoglobin switching over to adult hemoglobin in the months following birth. In beta thalassemia, that switch is obviously a problem because we're not making the beta chains. So that switch from the gamma to the beta is where we start to see issues. So with Casgevy, instead of fixing the beta globin gene directly, the gene editing takes a different approach, and it turns the fetal hemoglobin production back on. So it increases those fetal hemoglobin. And this is done using CRISPR-Cas9. So the CRISPR-Cas9 works like a pair of molecular scissors. I had to read so much about this because I did not understand it. So please, if anybody knows this more than me, don't judge me. But essentially it works like molecular scissors. And it's guided by RNA to a precise location in the patient's DNA where it creates a double-stranded break. In exa-cel, this break is made in the erythroid-specific enhancer region in BCL11A, where it disrupts a GATA1 binding site. And this leads to reduced BCL11A expression, specifically in the red blood cell precursors, while preserving BCL11A function in other cell types. And with this break in the erythroid-specific BCL11A control switch, the BCL11A can no longer suppress the fetal hemoglobin, and you start to have rising of the fetal hemoglobin levels, which then can pair. So the fetal hemoglobin is where you have the gamma pairing with the alpha, and you have functional hemoglobin again. And so this allows you to have functional erythropoiesis again, functional oxygen. Oh, perfect. Thank you so much. That's great. Thank you so much. And that's, essentially it works just by increasing your fetal hemoglobin. Now, this process follows several steps, but is very similar to beta-cell. So I don't know if I went through this fully with the beta-cell, but it's a very similar thing. So first, again, you collect the patient's stem cells via apheresis. You edit the stem cells. Again, this is in a lab with the CRISPR therapy. And then the patient undergoes chemotherapy to make space in the bone marrow. Sorry, I think I forgot to explain this with the last one. But essentially here, the important thing is that we have to give myeloablative chemotherapy with busulfan to essentially wipe out the bone marrow that exists for the patient, because if we were to just give them these edited cells back, there's limited space in the bone marrow. They wouldn't be able to engraft. And so we have to wipe that out and provide space for these new edited stem cells to come in and to proliferate. So we give that chemotherapy, and then we re-infuse these edited cells back into the body, and then they're able to settle into the bone marrow to begin producing the red blood cells with that increased fetal hemoglobin. So to summarize, the way this one works is that instead of replacing a broken part like we see with beta-cell, we just remove a blocker, remove this switch, or turn on the switch to allow for an increase in fetal hemoglobin. So how has this one worked? So in clinical trials, including the CLIMB FAL 111 and CLIMB 131, which was a follow-up study, these were open-label, single-group phase 3 studies in patients aged 12 to 35 with transfusion-dependent thalassemia, including all genotypes, with results that were published in the New England Journal in 2024. This has shown that 91%, so 32 out of 35 patients, were able to achieve transfusion independence with a mean hemoglobin level of around 130 grams per liter. And their mean fetal hemoglobin level was 110, so primarily made of fetal hemoglobin. Improvements in iron overload as well as erythropoiesis markers have also been seen, and to date no malignancies have been reported, though long-term follow-up is ongoing. I think the really exciting thing about this is that St. Paul's Hospital and BC Children's Hospital were actually involved in this trial, and this is we are going to be hearing from one of the patients right after this presentation. And this is just, I think, a really profound figure from the trial that shows the red blood cell transfusions before and after Casgevy. So the left side shows the 24 months prior to the Casgevy therapy, and each purple dot represents a transfusion given in that time frame. The right side shows Casgevy therapy, and the green shows time without any red blood cell transfusions in the study. So as you can see, the vast majority of patients achieved sustained transfusion independence after receiving Casgevy. It's pretty incredible. So access and availability, this is really the big question. So in Canada, despite these very promising and potentially transformative results, gene therapy is not currently available outside of clinical trials. The lentiglobin viral vector therapy with beta cell was approved by the FDA in the US in 2022, but it has not been approved by Health Canada and is not currently anticipated to enter the Canadian market. Casgevy has received Health Canada approval, and price negotiations are currently ongoing at the provincial level. It did receive FDA approval in 2023, and so is in the US. Locally in BC, we are working to expand the capacity of our transplant program because this is essentially an autologous stem cell transplant, so we do need to improve the capacity of our stem cell transplant programs and adapting our current infrastructure, which really is designed to treat oncologic patients or oncology patients. We need to adapt it to better serve these individuals who have a non-oncologic but of course still very life-threatening hematologic condition. And of course, on the global scale, this is challenging as the vast burden of transfusion-dependent thalassemia is in low and middle-income countries, and so we don't know what the price tag of this will be yet in Canada. Those negotiations are ongoing, but it is extremely high and likely not accessible for many of the patients who live in these countries. So, to summarize, thalassemia is a disease driven by globin chain imbalance, leading to ineffective erythropoiesis, hemolysis, and iron overload. Treatment has evolved from supportive transfusion therapy to potentially curative approaches. The lentiviral gene addition works by introducing a functional beta-globin gene. The CRISPR-based gene editing works by reactivating fetal hemoglobin. And both strategies work to address the same underlying problem through different mechanisms, but do seem to be effective. And so these advances represent a major shift towards transfusion-free therapy for patients who were previously transfusion dependent. And that's that. I would love to hear questions. I can't guarantee I'll have answers, but I do have Dr. Merkley here, who's one of our local experts, so please.
Hi, is this working? It is. Okay, so wonderful talk, the exocell. Now, one of the other major problems is sickle cell disease. And as you know, a high F level on a genetic basis and also induced by medications is protective. Do you see exocell as being a potential treatment for sickle cell disease?
Yes. And that is something that is currently being studied. Actually, I think approved as well for sickle cell. Yeah.
Thank you.
Yeah, very exciting, totally.
Thank you very much for joining us.
Thanks for having me.
So how much of the alpha chain dimer has been sopped up by introduction of the new beta chain? Have we conquered that problem?
So the ineffective erythropoiesis, they've been looking at it by looking at the ME ratio in the bone marrow, and it does seem like there is significant improvement, though there is still some degree of ineffective erythropoiesis with a higher erythroid ratio there. The actual sopping up, I don't know if we have a way of saying exactly how much it's sopped up, but I think just by raising or trying to fix that imbalance, certainly a significant portion of it. But there still is clearly some, because we do still see some ineffective erythropoiesis happening.
So we may have to still consider that clinical issue.
Yeah, for sure.
And with loose
Loose-powder sept?
Yeah, that one. Do I recall correctly that there was a significant thrombotic risk with that drug?
Yes.
Do we understand what the basis is? Because I don't understand that.
I don't think we do. I was reading through their study too, and I don't think we totally do understand. I'm not sure, Dr. Merkley, if you understand it better, but I don't think we do fully understand it.
So one of the major hypotheses is because you're maturing still very abnormal red cells, they're still going to be more prone to hemolysis and vascular activation, and so that is thought to be a main component of the thrombotic risk. They're not normal red cells that we're producing. They're enough to make it so that the patients require less transfusions, but they're not like a normal fully hemoglobin A containing red cell.
And the other thing, Dr. Merkley gave an excellent talk recently, is that we are in some patients seeing increased extramedullary hematopoiesis in patients with loose powder sept. As we have some improvement in that ineffective erythropoiesis, some patients are seeing massive splenomegaly or other extramedullary sites. So it's an interesting thing that we're seeing kind of post-trial.
Thank you for the talk about the new treatment. I have a kind of general question about how early the kids can be accept this kind of for treatment. Like, is there a limitation? And also, if this can be like testing, say, when they are pregnant, is there any way we can maybe preserve the cord blood for maybe the stem cell for the further like gene editing? Yeah. Thank you.
It's a great question. I don't know the answer. So in these studies, there were children age 12 and up included in it. Currently, it's not approved for children as of yet. I'm not sure about preserving from birth. I'm not sure. I'm not sure if Dr. Merkley, if you know anything about that, but we should just give Dr. Merkley a mic to also be able to comment.
Sorry, was your question regarding preserving fertility for patients undergoing the treatment? Oh, cord stem cells.
Yeah.
Yeah, so, I mean, transplant in thalassemia, as Jessica mentioned, is pretty experimental. We know that sibling donors are going to be the best and most effective. Cord cells have lots of problems with them in terms of transplant and increased risk of infections and poor engraftment and things like that. So, there's a lot of experimental transplant protocols looking at different forms of donors, but for the time being, it's still matched sibling donors as opposed to cord donations.
Thank you. So what's the physiological basis for why we lose fetal hemoglobin? There must be some biophysics reason why it's evolutionarily constrained and expressed. So then what is the downside of having fetal hemoglobin in adult cells?
Great question.
Still better than nothing, but...
Yeah, totally. No, it's a great question. So in utero, fetal hemoglobin has a higher oxygen affinity than our adult hemoglobin. And in utero, part of what we have to do is get oxygen across the placenta. So that's why we have that in utero. And so we do know that patients with fetal hemoglobin will have a higher oxygen affinity. Interestingly, there is a phenomenon called persistence of fetal hemoglobin, where some people have essentially just persistence of their fetal hemoglobin, will have lifelong high levels of fetal hemoglobin. And that's actually how some of the basis for Casgevy came about, was seeing that those patients with persistent fetal hemoglobin who also had beta thalassemia would have a much less severe phenotype. And so for those patients, we have seen no clinical downsides to having persistent fetal hemoglobin. But is some question, absolutely, and I think we'll have to see with time what the effects of having the majority of fetal hemoglobin will be. There are some thoughts that perhaps it will increase things like leg ulcers and things if we're not having as good oxygen delivery to tissues, but we're not seeing that so far. So I think that will be something we see with time, but that is the basis for why we have that in utero and then the switch to the adult world. Yeah.
Excellent talk. This question is, the transfusion requirement is decreased, but you didn't talk about these patients is there any requirement for iron chelation treatment, or how that is being improved?
Yeah, so the majority of patients, in follow-up with time, the majority of patients have been able to come off of their iron chelation. So most patients still did restart chelation after getting the Casgevy, just to reduce their iron stores that were still there even prior to receiving the product. But most patients have actually been able to come off of it altogether, come off of their chelation, and we will hear about that actually. That's part of Emily's story that we'll get to hear about as well. But yeah. Which is huge, because that's a huge burden. Yeah.
I have an online question from Dr. Ross McGilvery, who's curious about how much the gene therapies cost.
Yes. All right. So we don't know what it's going to be in Canada at all. That is still under negotiation. We really don't know yet. In the U.S., it's been quoted at around $2.2 million per patient, U.S. dollars. Sorry, we should give Dr. Merkley the mic for that.
So there are economic analyses looking at the lifetime cost of treating patients with thalassemia, and it's in the millions of dollars. So that price point is actually cost effective.
Yeah. Yeah, so the European, I'm not actually sure. I know part of why, so it initially for the beta cell was approved in Europe, and then they actually withdrew their marketing in Europe because they couldn't come to an agreement on cost, and so that has been permanently withdrawn from the European market. I'm not actually sure how much the Casgevy is costing in Europe. I'm not sure, yeah.
Once Casgevy is approved in Canadian provinces, what would be the eligibility criteria for patients to receive this treatment?
Yeah, I think we'll have to see, and it'll depend on our capacity, but I suspect it'll be similar, like adults who are transfusion dependent, but we know that we want to intervene sooner than later because of all the end organ damage that accumulates with time and makes people more susceptible to complications of that myeloablative chemotherapy. So I think ideally they will be obviously transfusion-dependent patients with beta thalassemia, but who also have, we'll have to go through and see for evidence of their end organ function to make sure that they would be able to tolerate the treatment, because it is quite intensive, that myeloablative chemotherapy part, but we don't know totally yet.
And just a follow-up question on that, are there any ongoing studies about like the feasibility and safety of this treatment in younger patients? As you said, it would be more effective if we started the treatment earlier.
Yeah, so the studies are still ongoing just for long-term follow-up. So these patients had the option of being enrolled in long-term follow-up, so those studies will continue to come out, and we'll see more of the long-term safety profile, I think, as we see the published results from those studies. Yes. Yeah.
Sorry, pediatric study ongoing for children as young as 7.
Fantastic talk. How many patients, if you had the availability and the infrastructure and the resources, how many patients do you have who could benefit from a transplant or gene editing today?
How many do you think in our clinic, Dr. Merkley, would we have? 50? 50, yeah.
From a health economic point of view, it's fine to say a lifetime, it's economically reasonable, except it's a cash flow issue and an infrastructure issue. Yeah. And that's in Canada. We're not talking about, other parts of the world.
Yeah, I mean, the interesting thing with beta thalassemia majors, actually our numbers have been fairly stable. They haven't been increasing quite as much as things like sickle cell disease or non-transfusion dependent thalassemia. And that's in part because so many countries have very effective preconceptual counseling programs. So actually the incidence is decreasing over the decades. So, we have a current cohort of patients, but I'm not expecting that our numbers are going to keep increasing as they have been for things like sickle cell disease, where many of our patients are coming from countries where there's no screening programs or preconceptual counseling programs. And so numbers continue to increase exponentially.
I think that ends my time, and I want to leave time for our next speakers. So thank you so much.